This animation will demonstrate how natural hearing works. The outer part of the ear, the pinna, catches approaching sound waves and funnels them down the ear canal. Both the pinna and ear canal naturally minimize background noise while selectively amplifying frequencies specific to human speech. As the sound wave reaches the end of the ear canal, it causes the tympanic membrane, commonly referred to as the eardrum, to vibrate and engage the three tiny bones of the ossicular chain. First the malleus, then the incus, and finally the stapes. These tiny bones act as levers magnifying the vibration picked up from the eardrum on its way to mechanically stimulating the cochlea. The stapes transfers the mechanical energy from the vibration to the cochlea by pushing the cochlea's oval window. This causes a wave to travel through the fluid-filled cochlea, stimulating thousands of tiny hair-like cells, which send an electrical signal off to the brain for interpretation. The result is you're hearing a sound.
Talk about motivation. I mean, I have to wear them or else I wouldn't function.
Did you have Meniere's?
Excuse me?
Meniere's? Is that
I believe I had it as a child. Yeah. And of course, they didn't know what was wrong.
Oh, wow.
Well, Joe, I guess you could start, and if they walk in,
How do I
they
turn
walk
this
in.
off? Just
Put it to 0.
there we go.
Okay, we'll get started. Thank you everyone for joining us for today's Grand Round. We have Dr. Novak. He is the director of the Center of Excellence for UTHSCSA Communication Sciences and Disorders. He's here for us. Here at the GREC, he's a research scientist who sees patients with the audiology service. Nick earned a bachelor's in general science, speech, and hearing science, and a master's degree in audiology, and a PhD in audiology, hearing science from the University of Iowa in Iowa City.
Yay, Hawkeye!
Go Hawks! On his way to the Alamo City, he was a faculty member at San Diego State, Virginia, and Purdue Universities. Dr. Novak currently serves as the American Speech Language Hearing Association Vice President for Standards and Ethics in Audiology. He was a popular speaker in the recent Summer Institute in Aging, and today he will speak to us regarding the aging ear. So give him a round of applause.
Hey, thanks everybody for being here. Today I'm just talking with you about how you can help your patients with hearing loss. Take the loss out of hearing loss is our goal. Prevalence, it's a very prevalent problem. Over 31 million people in the United States have hearing loss, and yet in terms of getting help, about 24% are getting help. So there's a huge unmet need for people with hearing loss, and it affects all aspects of a person's life. You don't look hearing impaired. That's one of the problems with this handicap, is that you just look like everybody else. And people don't understand it who don't have it. They confuse the behaviors you have with other things, that maybe you're just stuck up and you don't want to talk to them when you don't hear that they actually said your name. And often the person with the hearing loss is the last person to know they have the problem. Everybody else around them knows it before they do. Some of the kind of important statistics are that 32% of individuals over 65 have hearing loss. 40 to 50% of our 75 and older population have hearing loss. So you can figure just every other one of your older patients has a problem. It's the most service-connected disability next to tinnitus. So hearing loss and tinnitus, the highest service-connected problems. It's just some terminology. Hearing loss is just that physical problem with your hearing mechanism, outer, middle, inner, and central auditory system. The loss of that capacity. Hearing difficulty, hard of hearing, this is how someone perceives their hearing loss. Hearing impaired is a term that we try not to use because we are not talking about these folks as impaired people. We're talking about them as people with a hearing loss. So people themselves then talk about their hearing problem or maybe their handicap, their hearing handicap, in terms of how they internalize the effect of hearing loss on them. Hearing loss associated with aging is called presbycusis. Some of the symptoms of presbycusis: speech of others seems mumbled or slurred. High-pitched sounds such as S and TH are often difficult to hear, differentiate. Often say, I hear men better than women. Certain sounds seem to be annoying or overly loud, which seems to be kind of a paradox. I can't hear you yet. You don't need to shout at me. It's a very short kind of margin there for people with sensory neural loss. They often complain of sounds in their ears, ringing, crickets, buzzing. They say they hear you, but they don't understand. They often speak louder because they're trying to hear themselves. It's a natural reflex that we do. They need sounds to be louder, to be heard, but very quickly sounds are too loud. Hear sometimes better and sometimes than others, and usually the times when they hear better, it's quieter, and people who are talking to them are closer and they can see their face. Hearing is much worse in group situations rather than one-on-one, and they often are successfully tired at the end of the day just because they're straining to keep up and listen. They often answer questions they weren't asked because they misheard the question. They're often irritable, maybe negative, some anger, fatigue, tension. Some feel social rejection, loneliness. They kind of reduce their scope of what they're doing, their activities. Reduced job performance, earning power, diminished psychological overall health. We find it just cuts across every aspect of a person's life. People with it are often misunderstood. They're often, say, referred to as spacey, inattentive, preoccupied, maybe not too bright. If you're older, absent-minded, or demented, or maybe Alzheimer is setting in. So all sorts of other things are attributed to you other than you have hearing loss. Question to yourself, just to rhetorically ask, have you ever imposed those kinds of symptoms on your patients when they may in fact have a significant loss, and it's not any of these other issues? It affects the entire family. One hearing loss in the family is a family problem. So the need for family-centered intervention is very important in terms of bringing the important family members into your intervention with the person with hearing loss. It adds to the stressors in a family. It's just one more thing with polypharmacy issues, for example, remembering to take their medications, issues of blood pressure. The question for the individual is, where does it fit into their priority in terms of stressors? Is it an important problem, and is it something that they have the capacity to try to address? And it really is the patient's choice. Looking at it from a patient-centered point of view, we've got the hearing loss in the patient, we've got the goal of acceptance and rehabilitation of that hearing loss. What's our role is to help them bridge that gap to get there, realizing that they have the loss, wanting to do something about it, taking responsibility for their own rehabilitation, which is a goal that we have for patients across kind of what we're trying to do across diagnostic categories. So to make this change happen and facilitate this change with patients, first they have to admit they have a hearing loss to themselves and to other people. And why is hearing loss so hard to acknowledge? Just some thoughts.
Good question.
Embarrassing, maybe?
Yeah, embarrassment.
Maybe a person is denying they have a problem, so that's kind of fundamental. They may be procrastinating and saying, well, they told me 7 years ago that I had a hearing loss, but I still don't think it's bad enough to do anything about it. And we find the research says that between the time of diagnosis of a hearing loss and saying you've got a problem to getting a hearing aid, it's about 7 to 10 years historically.
Wow.
Not a good statistic. It doesn't occur overnight, and so people don't realize they have it. It's like going up in the mountains and all of a sudden your ears pop and boom, you're hearing better, but you didn't realize you weren't hearing poorly. You know, when your hearing becomes a little damped or deadened because your Eustachian tubes hadn't opened up and your middle ear, your eardrum is stiff and it's not working like it should. They often first lose the F, the F, and the sh, and the And so they attribute that to people mumbling. They hear people loud enough, but everybody mumbles. Why don't they teach people to speak clearly anymore? It's an admission of old age. That's kind of been one of the major issues.
True.
I'm old.
It's kind of that last vestige. They'll do everything else. And I'm sure we can think of other reasons. How do you let somebody know that you have a hearing loss? Well, you tell them. You say, I've got a hearing problem. This situation's really hard for me. I need to really watch your face. Can we turn up the lights and turn down the noise? So helping people to do that is a goal, and it's hard. Realize that hearing aids do not restore hearing. They're not like eyeglasses. When people make that analogy, eyeglasses are trying to fix the conductive system. It's a lens problem. But the sensory end organ, the retina, is in good shape in most cases. Hearing aids are trying to fix the sensory end organ and the central auditory disorder. And usually the conductive system is fine. The outer ear, the eardrum, the middle ear. So that's the difference. Hearing aids are trying to help a broken sensory system. Glasses were trying to help distorted conductive system. Realize hearing aids are not the only solution to hearing troubles, but they're the essential component. So if you need a hearing aid, if you have enough hearing loss to have help from a hearing aid, that's kind of the foundation of our rehabilitation program. The technology is great. And most importantly, your family needs to understand, and they need to be a part of your total rehab program. They need to know that they can't talk between rooms and allow you to hear what they're saying. And we'll talk a little bit more about this. Who said this? Blindness separates us from things, but deafness separates us from people.
Helen Keller.
Good
Get an
job.
Helen Keller. And the person with the hearing loss is ultimately responsible for their success in rehabilitation. Others can't do it for them, but you as primary care providers are so powerful in your ability to encourage them to go and do the next step in terms of what's needed in terms of hearing rehabilitation. Talk briefly about ear anatomy. The peripheral auditory system consists of the outer, the middle, the inner ear, the outer ear canal, and the eardrum. And what's so interesting about the auditory system is it's very finely tuned to receiving and emphasizing particularly the frequencies that are important for speech and communication. So that ear canal is already, in terms of its shape and volume, amplifying, resonating, particularly in the area of 2,000 to 4,000 hertz, which is where the consonant sounds are located in speech. So to hear the difference between shaw, saw, faw, you need that 2,000 to 4,000 hertz frequency region, and this is already amplifying it before it even gets to your eardrum. So it's, I think, I say it's a divinely evolved system in terms of how it is so tuned to communication. If we had elephant ears, we'd be listening primarily to lower frequencies, and it wouldn't help us a bit. The middle ear, eardrum, the ossicles, the Eustachian tube. The important thing about the older ear is that in most older folks, the outer ear, the eardrum, and the middle ear ossicles and Eustachian tube are in good shape. So the conductive system is often not the problem. Although we are seeing older individuals who are having allergies for the first time, which means that their Eustachian tube may not be functioning because it's swollen because of the hyperinflammation of the mucosal lining. So they're starting to have problems with fluid buildup where they just never had that before. We see that otitis media in kids, but now you may be seeing it in some of your older patients because of ineffective Eustachian tube function.
Have you noticed that between San Antonio and other places where you work and here, the prevalence is higher here?
Is it? Well, yeah, of allergies?
Yes.
Prevalence of allergies?
And hearing related with
and middle ear problems in adults?
Because we see it a lot in primary care. But you came from other places, so
Yes.
I'm wondering if you have noticed the.
Well, I've only been here a year,
Oh, okay.
but I would expect that that's the
Is that like Mount
situation.
Cedar
Oh, yeah.
allergies and things
The
like
Mountain
that?
Cedar is a
Yes.
big deal.
Yes, even younger people, you notice hearing impairment getting worse in the high seasons of that because you are struggling with allergies.
And that's the problem in the system. The Eustachian tube is not working well. Their middle ear fills up with fluid, the eardrum becomes distended, and you get a conductive hearing loss. And I'll talk about that in a minute. The inner ear has both the hearing and the balance component, vestibular and the cochlear system. This is where the problem with aging occurs, the loss of hair cell sensory end organ function. Inside the cochlea, you've got this nicely laid out, if you would lay it out in a flat kind of array, you'd have this nicely aligned tonotopic array of where all the little hair cells that respond to sound are located, with the hair cells that respond to high frequencies located in the base of the cochlea, down in here, and the ones that respond to low frequencies way up here at the apex. And typically, one of the reasons we think that you see so much high frequency hearing loss is that every sound that comes through this cochlea starts down here. It's called a traveling wave. So this part of the system is always vibrating, and it just gets worn out or earlier than the rest of the system, is one theory. The organ of Corti is where all the action is for the sensory end organs. This is what changes the vibration of this little basilar membrane here. And on it sits these hair cells with their cilia, which are attached, some of them attached to this tectoral membrane. These are supporting cells. And when a sound is coming in, this whole thing goes up and down. And depending on where the frequency is will depend on which of these hair cells are being displaced. High frequencies at the base, low frequencies at the apex of the cochlea, and then everything nicely laid out in between. So you've got issues of hair cells, outer and inner, and you've got their cilia, you've got these mechanical connections, and a lot can go wrong with all of that, particularly with noise damage. When this system is just walloped with a big pressure wave, these things can be damaged or destroyed in the process.
I have a question.
Yes,
When you go to Gold's Gym,
yes.
they're doing the Zumba classes, they're doing the exercise classes, but everyone, I've been to 3 or 4 of them, the noise level is absolutely tremendous. And the instructors, and I've asked them many times to turn it down. They'll turn it down, but then they'll turn it up again.
Yes.
But I don't know if the class is recognizing that, but I see it as a big possible public health problem.
Yeah.
All the Gold's Gyms, and they're all doing the classes, and they have the big speakers are up in the center of the room. They're 2 big speakers, and you just can't get away from them.
Yep.
Even regardless of where you go in the room. And my ears hurt, so I usually leave the class.
Yes.
And I'm paying my dues too. But that is a problem that we need to, I don't know how to address it, but I need to bring it to their attention that it has to, over the long term, because seeing what you're saying here, I can see you.
Yeah, it is noise is a public health problem, and wherever you encounter it, whatever you can do to try to minimize it or get rid of it is my challenge to you all, to all of us. And in that case, they should be handing out disposable ear protection, right? The little disposable
Yeah, that's a
yellow
good
ear
idea. You
plugs.
can give them.
Disposable
The ear
protection,
plugs.
little
You know,
Ear
those
And I'll
plugs.
talk about this in a
like they
minute.
have in the
Okay, the
military.
foam one, yeah.
Yep. And I'll talk about when is noise too loud, kind of determine that. But these are normal cilia. These are cilia that have had too much noise exposure. And these may pop up with maybe 48 hours of rest, or they may not, and it may be permanent damage. This is the central auditory system. So here is that all-important sensory end organ, the cochlea, sending out its auditory nerves, first order, second order, third order, fourth order, up to the auditory cortex, where we hear and make language. What we can see here is that there are a lot of way stations along the way where things can go wrong. And we're not very good at diagnosing where along the way the problem is. Types of hearing loss: conductive, a problem with the outer middle ear, so earwax impaction. Big deal in our veteran population. If you can develop great protocols for getting rid of it. If they come in, you see it, please take it out if you can yourself before you refer them on, for example, to audiology. And so that's a goal we have, and I would love to see 100% outcomes on that. Perforated eardrums, fluid in the middle ear, head trauma that breaks the ossicles apart, all of those cause conductive hearing loss. I'll tell you what that is. Sensory neural damage to the cochlea, the eighth nerve, the central auditory pathways. Due to illness, ototoxic drugs, noise is the big issue in our vets. Loss of blood supply to the cochlea can all cause sensory neural loss. And mix is a combination of both.
I have a question about the trauma. Have you looked at the effect of IEDs? The pressure waves?
Oh, yeah, I mean, that certainly causes severe sensory neural loss.
Have good
causes
studies been done on TBI and IEDs with
They're
hearing loss?
evolving because this is such a new area. We know that, at the surface, they have lots of hearing loss. Severe, profound sensory neural hearing loss due to that pressure wave. They also have other issues, central auditory system processing problems. The extreme would be the aphasic individual who maybe can understand what you're saying, but they can't express anything, or vice versa, or global, being they can't understand or express, and they just gibber. They say things, but it doesn't have any relationship to anything in their world. So all related to head trauma. And the challenge is to differentially diagnose what the issues are for a given vet, and then try to facilitate patient-centered intervention.
Are they doing hearing loss assessments in the field?
Yes.
For veterans?
Yes.
Exposed?
Yes. Yeah. But often the problem is so global that the hearing is just, a smaller part of the overall problem.
I have another question. You mentioned
Yes.
that the little tiny hair cells sometimes take 48 hours after kind of an attack or an injury. Some of them can require their permanence. 48 hours is the period that if you have somebody with an acute loss of hearing, will you...
Secondary to noise exposure.
Noise.
Yeah, I mean, if after 48 hours you're not seeing some recovery, then the odds are that it may be permanent. We talk about temporary threshold shift. We talk about permanent threshold shift.
Okay.
And if you come out of a rock concert and your ears are ringing, sounds are sounding damped or deadened, and you just feel like you're not hearing well, that's a sign of temporary shift. And maybe in 48 hours the tinnitus will go away and the hearing will come back, but what we're finding with research is that processing of those cells really never does come back to normal. Your thresholds may come back to normal or better, but how you're using that sound above threshold isn't normal. So to avoid to avoid noise damage is huge, and it's preventable. So in terms of your point, it's a public health issue. It's one of those things that we can prevent, we can intervene. The problem with sensory neural hearing loss is that, yes, they have hearing loss as evidenced on the audiogram, but it may be due to damage of the outer and inner hair cells. It may be stria vascularis, spiral ganglion cell damage, first, second, third order auditory neuron damage, synapse dysfunction, central cortical dysfunction. We're not very good at differentiating, and that's why we see such variability, I think, across our older population with hearing loss. Given similar audiograms, they may have very different processing problems. This is an audiogram. I tell my patients this is like a piano, the bass and the treble notes here and everything in between. And these are particularly the frequencies that are important for understanding speech, 250 through 8,000 hertz. This is the loudness of the sound that I'm presenting to you, and these marks are the right ear of the red, the X of the left, they're in blue, the O's are in red, are the softest sounds I was able to get you to hear today. And if all of your marks are between 0 and 25 on this graph, you've got normal hearing. And if then any of these marks are beyond that, then you've got hearing loss. We talk about normal, mild, moderate, severe, profound, but that really only describes, and you can see you can have different degrees of loss at different frequencies, but that really doesn't, it only describes the threshold location. It doesn't really fully describe the handicap that the hearing loss is in putting on to the individual with the hearing loss. This we would say is a bilaterally symmetrical normal hearing, 250 through 1,000, sloping precipitously to severe hearing loss at 4,000 and 8,000 hertz. It's a way to describe that. We can impose on our audiogram the speech sounds. So this says in normal conversation at about 3 feet, the speech sounds are vowels, some of the voiced consonants, o, ah, oo are in the lower frequencies. Higher frequency voiceless consonants, s, sh, are very soft and very high frequency. So if you're going to hear all of those, you really need good hearing sensitivity out through at least 6,000 hertz is our goal. So primarily vowels, mixed vowels and consonants, primarily consonants. We would say this person with this mild to severe bilaterally symmetrical loss is probably, if we were going to predict how they're doing, they say, I hear you, but I can't tell one word from another. So if they hear saw, sue, if they have saw, shaw, thaw, all they hear is the aw. They wouldn't hear the consonants. And so when they say, I hear you, but I don't understand you, that's what they're doing. I want to give you an example here. Let's see if I can make this work. Just of what it sounds like to have a hearing loss, one of these high-frequency hearing losses.
In the next demonstration, you will experience speech as it would sound if you had some high-frequency hearing loss yourself.
Nice and clear.
You will hear 4 sentences. However, they will not sound normal to you since some of the high-frequency tones have been filtered out. See if you can understand all 4 of the sentences.
This is the audiogram.
Here we go.
Number 1. Let one about the people. Number 2. Those cities are looking. Number 3. Understand your own. Number 4. I like to say it when I drop it.
Well, how did you do?
Very good.
I heard number
Somebody
4.
chewing gum?
Yeah,
So what is
number
it?
4. I heard number 4.
I heard number 4.
The bottom line is, you heard, but
Didn't understand.
you didn't understand. And this is what these patients with these kinds of high-frequency audiograms are hearing themselves. I want to give you a tool that you can use at the bedside with your patients to screen their hearing. This is the Ling 6 sound test, and Socrates is doing a study with this right now.
Yeah.
But I wanted to alert everybody as to what this is. This is a test that we've used for years with kids to see if their cochlear implants and their hearing aids are giving good audibility for speech. And it assesses kind of a broad range of the frequency spectrum, but using speech. So you just say to your patients, I'm going to do a quick test of your hearing. Please close your eyes and just repeat after me. Ah, E, oo, sh, s. Thank you. And then you can record what they said. If they didn't hear this sh at all, you know they've got high frequency loss in that 3,000 to 6,000 region. If they didn't hear the M at all, you know they've got, that you're talking like this to them, that they aren't hearing much of anything. If they confuse the oo, the e, the ah, you said ah, they said e, that says they've got some mid-frequency hearing loss That's probably getting in the way of their ability to make that discrimination. So you can then say, all right, I know what's going on here, and you can then go to the next step. Use clear speech, which is our goal for everybody. And SACWIP's doing a study on this. So everybody, this is my goal, that every provider, everybody uses clear speech. It's a little louder, it's a little slower. Try to maintain your level throughout the ends of your sentences. I call it anchor speech, as opposed to don't drop the level at the end of the sentence, which we all do. And patients, that's probably the most important thing you're saying to them, and they lost it. Use shorter sentences and allow the patient to always see your face. So practice this in the mirror, practice it on a daily basis with your family, because it's not easy to do all the time. And if we did it all the time, we'd minimize the handicapping condition for a majority of people with hearing loss.
So I'm doing this test as you like. I'm doing this. So when I'm saying sh and s, like I feel like they're not heard. I mean, do they not hear anything, or is
They
it?
don't hear anything. So when you hear the cookie, not anything. Those cookies are delicious. You know, they don't hear the s at the end.
It's like
They don't hear
anything
on the
Okay.
cookies. So they're just not hearing it. So when you say s and you get no response, you know they didn't even hear it. They're not hearing it enough to confuse it with sh or if they give you some confused response, then that says they've got some hearing, but probably high frequency loss above, say, 4,000.
So what about the rubbing thing that you were taught to do with the patients? You go behind them and tell them close their eyes and you just rub the fingers or rub the hair. What is that equivalent to what the e?
Well, it's a high frequency sound,
Okay.
but the technique there is very important, and you don't really have any relationship to the real world with that. Also, if you really have to get it right in front of the ear canal. If it's here or here, who knows? So using speech at a normal conversational level without visual cues gives you something really to relate to how they're functioning. If you're really thinking about patient-centered evaluation and care.
And I'm sorry, one more question. So when you tell the patient is close their eyes and you are in front of them,
And you're in front of them,
In
say it
front.
about 3 feet.
3 feet,
So
okay.
just please close your eyes. With kids, it's harder, and you might have to use a barrier. But you run the risk of distorting the speech if you're putting like a paper up in front of you. So with adults, most of them will comply. Just please close your eyes. I want to test your hearing quickly. And then just at a normal conversational level, ah, e, oo, s, sh, and keep it all at the same level. So don't drop it at the end. So you've done shh, and now you do You know, you keep it all at the same production level.
Can it be mixed? Like I had a patient who had deficit for oo and sh and s. Can it be like that? Or?
Yeah, I mean, did they say ooh, but they said the wrong vowel?
I mean, he didn't hear it. I mean, when I said ooh, he didn't respond. So
At all?
no.
All right, well, you mark that. I mean, that's a clear indicator. And there may have been a noise in the environment when you said ooh. So somebody, closed the door right while you were saying ooh, that eliminated ooh, so they didn't hear it. So you really have to make sure your environment is quiet, conducive to doing this.
With patients with cognitive impairment, the only issue I have is the memory recall. So
Yes.
can you just repeat it to me at each sound?
Yes.
Ah, and just let
They
them repeat
repeat.
ah. Then you go E, they repeat E. Is that okay?
Yes, that's the way you're
Because
supposed to do it.
Ah, okay.
Yes.
One at the time.
Yes, so.
Oh, I
if
thought that
we-
you tell them all the sounds and then you need to
No,
remember all the
no,
sounds.
yes, I'm sorry. It's
Okay.
there to repeat after each
After
presentation.
each one, okay.
Yes, so I say
sorry,
ah,
thank you. Ah, okay,
E,
got it.
E, right. So no need for memory, short-term memory.
That's good.
And then this just gives you kind of what to do next. If they miss the S and the H, use clear speech. Always make sure they're able to see your face with everybody, and use clear speech with everybody. It's kind of the standard of oral care when you're delivering anything via speech. If they miss SHH and have some vowel confusions, clear speech, visual cues, and the comfort duet. And before we started, some of you were looking at this, listening to it. This is a little rechargeable amplifier. Has the ability to be either a flat, broad frequency amplifier or a high frequency emphasis amplifier. It's rechargeable. You just turn it on the mic and turn it down to 0, place it on the patient's head, and then have them adjust the volume, or you can, until your speech is comfortable. And they say, yeah, that sounds pretty good. And then say, well, we're just going to try to use this today during our clinical encounter. We did a recent quality improvement study, and the provider's perception of impact of hearing loss in their patients, they perceive a problem, number one, a lot of unrehabilitated hearing loss in our vet population. And they were very interested in the idea of having comfort duets in their clinics that they would use with patients or carry with them if they're doing in-home health care. These have little disposable earphone covers, so you can use different ear pads between each patient. So that kind of controls the vector.
What about the impact of physicians, for example, speaking over the, or any practitioner, over the telephone to folks?
It's a problem in telecare.
Because there's no visual.
Yes. So if it's phone only, it's a problem. Even if it's audio-visual transmission, you've got to compensate for this in terms of giving them good facial cues, letting them see your face. A lot of us will be doing our care, maybe talking like this, looking at notes, and so they don't see our face. And the issue of having good coordination of lip movement with what you're seeing at the other end. You know, as long as it's going with what they're hearing, with what they're seeing. If there's a delay for both, then that's okay. But if one's delayed and the other isn't, that's not good. That confuses the lip cues. Yep.
What about if you're on the telephone, if you're having a telephone, a long distance telephone conversation with a person, how would this work? I mean,
Well,
can they look at
there
the telephone?
is actually a telephone mode on there
Are they?
that the patient could use if they're listening on the phone.
Mhm.
And what that does is you then put the telephone up against that,
Oh.
and it picks up the electromagnetic field that's coming from the phone, and it
Wow.
minimizes kind of the amplification of what's in
Wow.
the room.
Oh.
So then they kind of use it upside down, they talk, and then they're hearing the phone through the comfort duet.
So this is
So this
your
is a-
best recommendation if we need to tell a patient to invest on something. This is the one that they should
This
get.
is certainly a very low-cost intervention, right? And it's great for our older folks, particularly who are in nursing homes, where they lose hearing aids. I mean, left and right, they get lost in the bed sheets, go to the laundry, go in the garbage cans. These are, you can see them, and the patients can have some independence in putting them on and manipulating them. So it's a great alternative when individuals aren't able to use hearing aids successfully. In terms of the independence factor, the willingness to wear it factor. Even if a patient uses it just for patient-provider encounters and times with their family, you know, they may say, I don't want to hear it, I don't want it the rest of the day. And you're fine, but I really want you to use it while I'm trying to communicate with you and for their family. And then they need some support to do that, some training to do that. So great
this is available
referral to audiology, you know, in terms of this sort of intervention, kind of what is the best and helping them learn to use it. Go ahead, I'm sorry.
I'm sorry, where is this available at?
You can get this through prosthetics. You can order them actually for a patient that you think needs it.
So the VA carries it, because we
The
all,
VA carries
we
it.
usually prescribe the pocket talker, but you're saying if we have
Yes,
this,
this is
it
an
will be
option.
the
Pocket
best.
Talker is made by Williams Sound. It has a removable microphone that can get lost. It's not rechargeable. It's bigger, kind of clunkier. So this is smaller, rechargeable.
But you can probably buy it also in the
In
internet.
the internet?
I'm
Yeah.
pretty
But
sure.
if the VA is gonna pay for that for a patient, that's a big
So
deal.
that's a good question. If you want this specific device, do you need to put much more documentation, or do they need to get an audiology eval, or?
The bottom line for the patient care is if you are seeing that hearing loss, or the patient is saying that hearing loss is interfering with their ability to fully participate in their care, then that's a reason for next step intervention, referral to audiology. And for you, I've got to talk like this to you, and it violates HIPAA, so everybody down the hall hears what you're saying. So it's quite possible you could, if you knew you had this patient coming in, that you could order from prosthetics and have it available and be able to pick that up in time for your appointment. So the question is, does prosthetics have the Comfort Duet in stock versus the Pocket Talker? And
Have
they
you
both the
ordered
same
it,
thing.
Laura? Have you?
No, I've only ordered Pocket Talkers.
That's
It's
what
very
I'm-
simple to do.
Yeah, same deal. It's
We
just a
can
different
try.
provider, and audiology has this as an option in
I mean,
terms
they
of
work
one or the other.
similarly, but they're not rechargeable, and they're bigger. Bigger is better for some people.
Yes.
But, yeah.
And this really is, I mean, it's cool looking, and it has a nice big volume control, and it doesn't have a microphone that you can lose. If we're looking at kind of assessing, enabling the patient to assess the handicap of their hearing loss, this is a tool that you might consider. It's the Hearing Handicap Inventory for adults.
That's expensive.
It has emotional, social questions on it. Does a hearing problem embarrass you when you meet new people? Yes, sometimes no. A yes is a 4, sometimes there's a 2, a no is a 0. So you can add a calculate a total score. If their score is 0 to 8, no handicap, 10 to 24, mild to moderate, 26 to 40, severe. So this is a nice tool. If they fail their Ling 6 sounds test, if they say, yeah, I have a hearing problem, then ask them some of these questions to see the next step in terms of how much it's impacting their life. And it may give you a sense of urgency of that next referral. Counseling is imperative in terms of prevention of noise damage. All patients, this should just be a very short part of what you do. Are you around loud noise? Yeah, I mow my lawn, I fix other people's lawnmowers, I'm listening to the engines. Do you wear ear protection? Well, no, but you should. Limit exposure time, exposure level for less damage. Options are these yellow kind of EAR disposable plugs, which you can get in drugstores. You can order them over the internet. They're great. They're kind of one-time use. These flange type, again, are across individuals, so they have different sizes, but they're not custom made. Ear muffs. Sometimes individuals who are in high noise levels, like on the flight line, wear both earplugs and ear muffs. And then we can also make custom hearing protection, where we take an impression of the ear and make plugs that particularly fit and are snug to the individual's ear, and they're not putting constant pressure, which at the end of the day can be uncomfortable. When is noise too loud? If at 3 feet away, I have to raise my voice to maintain conversation because of the noise, then it's potentially at 85 or greater. When it's easier to converse, when you put your fingers in your ears. So you get in that noise, you do this, and everything sounds clearer. That means the other person's also shouting, but you're not distorting your hearing. You're hearing them, and you're minimizing the background noise. So that's a clear indication it's too loud. And then if you have ringing in your ears, that sense of damped or deadened hearing when you leave, that indicates, yes, you have some shift of your hearing, and hopefully it's temporary. The problem with, for example, tinnitus, is that you can have one insult, like you're doing jackhammering for an afternoon on that sidewalk that you've been wanting to get rid of, your ears are ringing, and that may be with you the rest of your life. So it may not be the 48-hour gone, and in many cases it's typical that it is long-term. 3 levels of the use of sound. Communication, most obvious. We hear twins. Was that one twin they were talking about, or both? I saw the twin yesterday. I saw the twins yesterday. So you start to get confused. Was it both of them, or was it just one? Well, that's an indication that you're losing language information. That's the first to go with hearing loss. Alerting self-protection, you're in your home, the glass breaks in the back door, do you hear it or not? That's kind of the next level that goes. And then just keeping us a part of our acoustic environment, just hearing incidental stuff that's going around us. Which do you think is most devastating to the person who's lost all three in terms of their report? The last one. You feel like you're in a bubble and you're not really part of the human race anymore. It's a very isolating experience. At a minimum, what should hearing aids do? Really, the standard of care for delivery of hearing aids is what we call a real ear probe microphone measurement of how much sound pressure that hearing aid is putting into the ear canal. We can do that. So if we want to emphasize, and if these are frequencies along this axis and amount of amplification on this axis, for this patient we're providing more amplification in the higher frequencies for that high frequency loss. But what we've plotted here is their threshold, the softest sound they can hear, the loudest sound that they can comfortably tolerate, and then we're looking at what is the hearing aid doing in between. So we give them soft speech, it's amplifying it here, so it tells us it's above their threshold, so at least it's accessible auditorily to them. We give them average speech, it's kind of in the middle of this range, and we give them loud speech, and it's definitely louder, but it's still below their maximum loudness tolerance. And we're doing this in 5 minutes. And this then tells us, is this hearing aid functioning at supra-threshold levels the way it should? Or is it just not giving us anything? And the person says, boy, this sounds great. Well, you know why they say it sounds great? Maybe it's just like hearing without a hearing aid, and they love that, you know? It's the low-motivated patient who would give you that response. They're saying, yeah, it sounds great, but they don't know that, probably. And if you give them this high-frequency information, they say, boy, you just sound like you're sissing all over the place. And well, that's what I'm trying to give you, you know, the S's and the SH's. That's what you're missing. National Council on Aging study, do hearing aids change people's lives or affect them? Majority of hearing aids wearers reported improved quality of life. So if we're talking about patient-centered outcomes for people with hearing loss, improved personal relationships, 74%, self-esteem, 67%, improved overall health, 71% perceive an improvement in their overall health, but the family members particularly, 15% greater than the patients themselves, perceive an improvement in overall kind of life quality. Tinnitus, interesting thing, the research is showing back in 2011, not that long ago, that hearing aids can help about 40% of people with tinnitus minimize their awareness of tinnitus. Why? Because it amplifies the frequencies in their tinnitus frequency region from the outside, so they're not hearing just from their inside. So they're more in control, and also it may be covering it up a bit, or at least distracting them away from the tinnitus.
So you don't need to have necessarily hearing loss to do a referral for just tinnitus, can be a good referral for
Absolutely,
you guys.
yeah. The patient, the VA has a great tinnitus management program, and we give this workbook to folks who are particularly bothered. We have a group of audiologists over at Data Point who are very interested in tinnitus management in terms of group intervention. So if they're not particularly complaining of hearing loss, they probably have it, but tinnitus is their major focus, refer them to us, to audiology.
One more question. Some of my elders said I don't wear the hearing aid because I hear all the background noise.
Yes, and that the issue with hearing everything may be that the hearing aid is programmed such that it's amplifying too much of the mid and low frequency sounds. It's giving them more amplification in regions they don't need it. Given that, you know, those different slopes of hearing loss, well, we can, with the new hearing aids that are on the market, finely tune the amount of amplification we're giving by frequency region. So just send them back to whoever gave them that hearing aid to say, you know, I need it to reprogram. And hopefully they'll use real ear measurements, and they'll get a sense of how they're changing what they're doing for that with that hearing aid. Lots of different options. You hear of receiver in the ear canal hearing aids, which are these cool little mini BTEs with this little preformed tube, and they're fit often with just earbuds that are kind of standardized, open. These are wonderful for individuals who have fairly normal hearing in the lows and that high frequency loss. And it's a kind of technology that really has only come on the market in the last maybe 10 years in a great way. And so it really enables us to help folks who we otherwise haven't been able to help with that very high frequency nature of hearing loss. Often what those folks will say, if we tried to put these kinds of aids in their ears, they'll say, I hear myself like I'm in a barrel. I feel all plugged up. With these hearing aids, we don't get that. It's more of a satisfaction right from the get-go. Hearing aids can have little devices, streaming devices, that can stream via Bluetooth your cell phone, your TV, directly to both hearing aids at the same time. So very cool. Other devices, FM systems, the Comfort Pocket, Duet Pocket Talkers. These FM systems, you can have a personal system where you give the microphone to the speaker, and that microphone with a transmitter transmits directly to my hearing aid. So I pick up on the frequency of that transmission. You've seen them in churches and concert halls where you can check out a device with an earphone. That may be an FM transmission of what's happening on stage or at the podium, or maybe an infrared signal using light as the transmitting medium. Amplified telephones, you get those free through the state. It's true in every state. There's a little tax that we all pay that enables folks with hearing loss to get amplified free phones. I'm hoping that maybe that could be tapped for hearing aids, getting hearing aids for folks who couldn't afford them. It's meant for telecommunications, but hearing aids have telecoils, and telecoils enable you to talk on the phone as a hearing impaired person. So I'm hoping maybe we can expand the legislation to include hearing aids with telecoils for people who need it. So that's another hill that maybe we'll die on, but we'll try, right?
Good.
In terms of getting that
Thank you.
accomplished. If you're still missing some things that the person can do, try to arrange their environment. Sit away from the kitchen. If you're at a restaurant, sit over in the corner where it's less noisy. Sit in a booth. Ask folks, you were saying something about going to the store. I missed which store you were going. So help people to know, if they help people understand what they did here, their family's going to get less frustrated with it, rather than just saying, what, huh? What? You know, we all heard part of what was said. They need to learn to tell what they did here. Assertiveness. Let's turn up this light. I can't see your face. Let's turn down that noise. Let's shut the door. People with hearing loss need to learn to do this. And you can help them. And a referral to audiology is kind of an appropriate referral as well, because we can do counseling as well. The do's, do get a person's attention before you talk to them. Hey, Mary. She alerts, she knows you're talking to them. Face to face at all times. Don't talk between rooms. Speak slowly, or clear speech. Remove obstructions. If you've got a mustache, trim it so people can see upper and lower lips. Remove gum. And try to help patients keep their sense of humor. Oh yeah, I missed that, but hey, let's try it again. Tips to successful use of hearing aids. Today's technology is amazing. Hearing aids talk to each other. They can help with localization of sound. You turn up one hearing aid, it turns up the other. You change a program, it changes the program on both hearing aids. They're just wonderful devices. The technology kind of exceeds, I think, our ability to kind of apply it to patients in terms of helping them learn how to use it appropriately. In terms of that patient interface, that needs to be worked on. They need to be more automatic, fewer controls. And you can order a hearing aid with no volume control, no program control. It is pretty much all automatic. Some patients don't like that. They want the control. They're used to a volume control. So you have to work with, that's an audiologist's challenge in terms of that patient-centered approach. Successful folks wear them all day. They wear 2 hearing aids if they need them. Except a certain amount of imperfection. You know, the individual says, I just can't hear everything. You know, it's just, I'm distracted. You know, that it's just one negative thing after another. you know that's a rehab challenge, and we as audiologists are going to have to spend a lot more time with that person. Acknowledge that some listening situations are impossible. We got to go out in the hall. You know, there's a bunch of people, it's a cocktail party, I can't hear a thing you're saying, let's go in the hall. And they have to be able to do that. Open about their hearing loss to others, flexible in hearing what they said. You know, just, well, I know she didn't sweep the floor with a bone, it must have been broom. You know, so that, you know, you use all your cognitive abilities, which is harder for some of our cognitively challenged, and they're just stuck on one thing. Maintain a sense of humor, I think that's the biggest thing, and never apologize for your hearing loss. I have a hearing loss, you don't say, I'm not sorry I have a hearing loss. I have a hearing loss, and this is, I need you to look at me. You can help your patients take the loss out of their hearing loss, take charge, and this part of your patient's care, and refer to audiology. We're your greatest allies and friends. Speech pathology, in terms of the communication piece, tinnitus, we can help with that. So if a patient's saying, I just can't hear you, or you're having to talk loudly to them to get your point across, that patient's having a problem. They fail the Link 6, they miss one or more of those Link 6 sounds. It's a reason to refer, and they can qualify for hearing aids because it's impacting their ability to access their care. Questions?
Question, yeah. And the Link 6 test, is that something that we can do? Is a standardized test that can be done in the community or
Absolutely.
anywhere?
As long as it's quiet enough. So as long as a person at 3 feet can hear a normal hearing person, you know that that exists, then you can use this test.
Where is it? Is it available from which website?
Well, if you look up Link 6 sound test, you'll see a bunch of websites, but really that's all it is ah, e, oo. Sometimes you'll see the ah as ah, but it's not ah, it's ah. I saw that in one website.
Okay.
So the big thing is 3 feet, please close your eyes or have a barrier, but that's not preferred. Ah, e, oo, sh, s, and then you can do it with visual cues, and that will give you an idea if they're using visual cues effectively. The nice thing about high frequency sibilants that are so hard to see, they're the easiest, or so hard to hear, they're the easiest to see. So if I say free, see, she, 3, you can see those differences. Some people, you know, ventriloquists have no movement at all. So that's the extreme of no help from lip cues. But if you say, okay, now let's open your eyes and do it again, ah, e, oo, and they get 100%, then you can at least document they're using visual cues well. If it doesn't help them at all, then you can document that as well.
I was thinking of nursing using it as a tool.
It's
also
a wonderful
part of an
tool.
assessment tool. So then we would have to do a referral to the primary care physician in the community, right?
Yeah, or to an audiologist.
Or an
You know, if
audiologist.
they're not complaining of any other medical problems, they're not dizzy, they don't have ear pain, they don't have, it's just in my left ear, the unilateral, they don't have tinnitus. If it's not a new problem, and if they don't have foreign objects in their ear, you know, like their ear's draining, or there's a fly in the ear, which we've all seen, a bug of one kind or another, then you could have referred straight to audiology, who could then make the next referral if there's a medical referral needed. And then you could at least get the hearing assessment going, determine if it's sensory neural, mixed, conductive, which will inform then the next decision for referral. You've assessed whether they've got wax impaction, and if you've got time and you do that as part of your care in that setting, then you could take it out under your scope of practice. But our scope of comfort is different from our scope of practice, so even though we might be able to do it, we may not do it. And wax removal isn't just a cinch. Particularly in our older folks, it can be adherent to the ear canal, and they may have a perforated eardrum on the other side of this mass of wax. And if we go in and start irrigating, We don't know if we're pushing water into the middle ear through that perforation or not. So ideally, we'd like to get it manually removed, softened up first. But I've seen situations where there's been a too rush to remove approach, and it's ripped the canal skin, because some of the wax is canal skin. You know, it's sloughed TM, that outer layer of the TM is skin contiguous with your ear canal. That sloughs along with the skin tissue in the ear canal, along with the cerumen that's being produced, and it just creates this bolus of cerumen, we call it collectively. But it still may be, have you ever looked in the ear and saw what appeared to be an eardrum, but it doesn't have any of the landmarks of an eardrum? It doesn't have the umbo or the cone light, it doesn't have the short process of the malleus, but it looks like it's, what it is, it's that sloughed, and it's sloughed all in one sheet, outer layer of the eardrum that's just moving its way down the ear canal. I've seen that a couple of times. Have you ever seen that?
I saw that and I didn't know what was. I don't know exactly. Wow.
Isn't that something? And so that then requires manually, you know, removing it. But you have to know that that's what it is. That it's not just a very abnormal looking eardrum, very close to the entrance of the canal. Which it could be, but the odds are against that. You know, in terms, we've all seen very short ear canals where you take your otoscope, you pull back the ear, and boom, there's the eardrum. That's rare, but very short, straight ear canals. You know, and for those patients, you want to say, and for all patients, nothing bigger than your elbow in your ear, because it cleans itself, really. Just kind of make sure the outer part is dry after you take your shower in the morning. Make sure it's dry, and then put your hearing aids in, but no Q-tips, because we've all seen that.
Patients love that.
Oh my God, yeah, and they say, I've done this for years. Well, all it takes is that one muscle spasm that just shoves the Q-tip into your ear farther than you wanted, and we've seen that too, you know, and you get more of those as you age. So try to counsel them not to do that either.
So 85, your normal hearing, your decibels, right? Is 85 decibels is normal hearing
No,
levels? Or
normal hearing level 0 to 25.
Oh,
So if your
okay.
threshold's on an audiogram or in
Right.
that range, the 85 is that critical noise level that becomes damagingly loud.
Oh, okay, so 85 or above, that means you're going to get
That means
eardrums.
you have great
Severe.
potential of having sensory neural hearing damage. And kind of the relationship there, we say 85, 90 dB, OSHA says this, the Occupational Safety and Health Act. 85 to 90 for 8 hours is okay, allowable. And we're trying to bring levels down to that. If it goes to 95, only 4 hours gives you the same exposure risk. If it goes to 100, 2 hours, 105, only 1 hour of exposure gives you the same risk. 110, 30 minutes, the same risk as 85 to 90 dB for 8 hours. So what that says, there's this trading relationship, and the louder the sound, the shorter time you have to be exposed before you suffer
I think
damage.
it's probably like 300 at Gold's.
Pardon?
I think it's about
Gold
300 at
gym is
Gold's gym.
300.
After Zumba
At
class.
Gold's.
Zumba class.
Well, you know, that can be a UTHSCSA intervention at Gold's
Yeah, we
Gym,
need to
right?
test- I need to see how I can
Because
do
it's
that.
right here, right?
You are
Well,
right.
they have it here,
They ask students to have a mandatory membership.
Mandatory membership.
So
yeah.
there should be some input in terms of occupational medicine or who is the,
Absolutely.
to really help.
And to have earplugs available and to educate. You know, if you're experiencing having to shout in here to communicate with folks, then the noise is damagingly loud. We provide ear protection, which seems to be kind of a silly situation. You know, if they're saying that, then they should be reducing their noise levels. But that's a great intervention that we can all email and say, need to be disposable earplugs available to anybody who's going to
Yeah,
Gold's
I
Gym.
mean, and they're big, they're taking over all the other gyms now. They're all
Yeah.
over Texas. And
Yep.
that's a huge
Oh, it'd
problem.
be great.
Well, we're
We
going
could
to have a lot
publish
of
that.
deaf Texans that are really well fitted but deaf. So
There'll be job stability for them.
yeah, exactly. We're paying for your salary. That's
Any more questions?
Oh, thank
All
you.
right.
Thank
That was
you.
really good. Thank you.
You're welcome. You're welcome.
I want to know if the young football player can, does he listen or can he hear?
Where's
Have
the
a
name of
question.
the test?
I think his hearing's pretty good.
Six link.
All right,
I'm
everyone,
doing it.
thanks so much for joining us for today's grant round.
That would be
Don't
great.
Oh, you
forget
have a copy
to
of it.
sign in
Yeah, but
and
link six.
fill out the evaluation. You're gonna get your email today.
I'll have that.
Complete that,
But you have a-
and thank you so much, and
Thank you.
we'll see you next week.
Next week.
Same place, same
Thank
time.
you, ma'am.
Same bed.
Urology next week.
Urology, there you go.
Urology. Is there a number you end up with?